2026 CMS Prior Auth Rule, Complete Guide for DME Suppliers. This is educational content based on publicly available CMS data. It is not legal, medical, or billing advice. Always consult your compliance team for guidance specific to your practice. If you process prior authorizations for durable medical equipment, the rules changed on January 1st, 2026. The CMS Interoperability and Prior Authorization Final Rule is now in effect, and it fundamentally changes how payers must handle your PA requests. This isn't a minor tweak. According to the Department of Health and Human Services, this rule affects over 250 million Americans. If you're a DME supplier who has ever waited weeks for a PA decision, called a payer 5 times for a status update, or lost an order because the authorization expired, this video explains what changed and what you need to do about it. Section 1. What the CMS Interoperability Rule actually says. The full name is the CMS Interoperability and Prior Authorization Final Rule, Regulation Number CMS 0057F, published in the Federal Register. It took effect January 1st, 2026. The rule applies to 4 types of payers: Medicare Advantage plans, state Medicaid programs, children's health insurance programs, known as CHIP, and qualified health plans on the federal marketplace. Traditional fee-for-service Medicare is not directly covered by this rule, but CMS has signaled that similar requirements may extend to traditional Medicare in future rulemaking. The core requirement is this: covered payers must implement electronic prior authorization using standardized FHIR APIs. FHIR stands for Fast Healthcare Interoperability Resources, and it's the modern standard for healthcare data exchange. No more fax and phone PA submissions as the only option. The goal, according to CMS, is to reduce the administrative burden of prior authorization, improve transparency in PA decisions, and give providers faster access to authorization status. Section 2. New response time limits. This is the change that matters most for day-to-day operations. For urgent prior authorization requests, payers must now respond within 72 hours. For standard prior authorization requests, the response deadline is 7 calendar days. Before this rule, there was no federal time limit on PA response times for Medicare Advantage or Marketplace plans. Some payers took 14 days, 20 days, or longer. According to a 2024 KFF analysis, 4.1 million prior authorization requests were denied in Medicare Advantage alone, 7.7% of all 53 million PA determinations. And only 11.5% of those denials were ever appealed. The new rule also requires payers to provide a specific reason for any denial. No more vague rejection notices. The denial must reference the clinical guidelines used in the decision. This is significant because it gives you a concrete basis for appeal. You know exactly which criteria weren't met and can address them directly. Section 3. For API requirements for payers. The technical backbone of this rule is the FHIR 4 API standard, specifically the HL7 Da Vinci Prior Authorization Support Implementation Guide. In practical terms, here's what this means. Covered payers must implement 3 APIs. First, the Patient Access API. This allows patients and their authorized representatives to access their prior authorization data electronically. Second, the Provider Access API. This allows providers, including DME suppliers, to submit prior authorization requests electronically and check status in real time. Third, the Payer-to-Payer API. This allows data sharing between payers when a patient switches plans, reducing the need to reauthorize ongoing treatments. For DME suppliers, the Provider Access API is the game changer. Instead of calling a payer to ask, quote, "Where's my PA?" you can query the API and get an instant status update. Submitted. Under review. Approved. Denied with reason code. The Da Vinci Implementation Guide standardizes this across all payers. Whether you're submitting to Humana, United Healthcare, or Aetna, the API format is the same. This is a massive simplification compared to the current world where every payer has different forms, different portals, and different phone trees. Section 4. Impact on DME prior authorization. DME has historically been one of the most PA-intensive categories in healthcare. Power wheelchairs, CPAP devices, home oxygen, hospital beds, Nearly every high-value DME item requires prior authorization from at least some payers. The current process for most DME suppliers involves a combination of payer-specific portals, phone calls, and fax transmissions. Staff spend hours per day checking PA status and following up on pending requests. According to KFF, 4.1 million PA requests were denied in Medicare Advantage in 2024. The new rule won't eliminate denials, but it will do three things. First, it speeds up the process. 72 hours for urgent, 7 days for standard. You'll know faster whether to proceed with the order or pivot. Second, it provides specific denial reasons. When a PA is denied, you'll know exactly which clinical criteria weren't met. This makes appeals more targeted and more likely to succeed. Currently, most denial notices are vague enough that suppliers don't know where to start the appeal. Third, electronic submission reduces data entry errors. When you fax a PA form, errors are common: wrong fields, illegible handwriting, missing pages. Electronic submission through FHIR validates the data before it reaches the payer. According to healthcare IT research, electronic PA submissions have significantly lower error rates than fax or portal-based submissions. Section 5. What DME suppliers should do now. The rule is in effect, but full enforcement rolls out in phases through 2027. That gives you a window to prepare, but not a long one. Action 1. Contact your practice management system vendor. Ask whether their system supports FHIR or FHIR connectivity for prior authorization. If it does, ask for the implementation timeline. If it doesn't, start evaluating systems that do. Action 2. Contact your clearinghouse. If you use Availity, Change Healthcare, or another clearinghouse for claims submission, ask about their FHIR PA capabilities. Many clearinghouses are building FHIR PA submission into their existing platforms. Action 3. Document your current baseline. You need to know your current PA volume, average turnaround time, and denial rate before the rule takes effect. Without a baseline, you can't measure whether the rule is actually improving your workflow. Action 4. Train your staff on electronic PA workflows. The fax and phone era is ending. Staff who currently manage PAs via phone calls and portal logins will need to learn the new electronic workflow. Start that training now. Don't wait until the tools are live and orders are waiting. Action 5. Review your appeal process. The new specific denial reason requirements make appeals more viable. If you've historically had a low appeal rate, and most DME suppliers do, revisit that strategy. According to the KFF data, only 11.5% of denied PAs are appealed. With specific denial reasons now required, the success rate of well-targeted appeals should improve. The 2026 CMS rule is the biggest change to prior authorization in a generation. It won't solve every problem. Payers can still deny claims, and documentation requirements remain, but it eliminates the black box. You'll submit faster, get decisions faster, and understand denials better. The suppliers who adapt first will have a measurable advantage in turnaround time and revenue capture. The suppliers who wait will continue fighting the same fax and phone battles while their competitors move on. If you found this helpful, subscribe to DME Insider. We publish new videos every week breaking down CMS rules, billing codes, and compliance requirements, all backed by public data. To automate prior authorization submissions with FHIR API connectivity, visit MyMedi-AI.com to start your free 7-day trial. No credit card required. Thanks for watching. See you in the next one.